is just for purposes of understanding this copay. What is it?
Copay is when a mother comes maybe for delivery, SHA will reimburse 10,000 for normal delivery. We will ask this mother either pay an additional 3,000 just in case that money doesn't come. At least I'm cushioned.
Yeah.
As a facility, you're cushioned.
Yes.
But in terms of fairness in provision of healthcare as provided for by the Constitution, is copaying a standard practice?
The SHA Act allows copay. The only caveat is the patient or the client should consent.
So can they decline? If they cannot afford it, what happens?
Yeah, if they cannot afford, you make a choice. Either to do a CSR or to refer them to the next available.
But can we look at that SHA Act? Because I'm still trying to understand. And I don't know, was I asleep when we were told very clearly that this universal health coverage meant that because of a premium that you pay and the responsibility that government takes, that means you go to a medical facility, you get treatment, you leave without having to pay an extra coin based on the fact that you have paid your premium. I mean, it's sad that we have to go back to this, but I just want to understand, unless maybe I missed something. But this is what we were told, that UHC means that you won't have to. So if we're saying that the SHA Act provides for copay, does that mean that there was already a foreseen situation whereby this foundation that everybody understood was to be the case would then not be possible?
Now, we need to understand that SHA provides service in different stages.
Yes.
One is the PHC, the primary healthcare. This is where we are told that the moment you register, you can walk in and walk out in a level 2, 3 and select level 4 and be treated and go.
Is that the case?
It's not the case.
It's not.
Because this PHC is public funded, is exchequer funded, and many times we found that Parliament has not appropriated enough money.
So the money is not there.
Yeah, the money is not there. So even if you walk in, what will you be consuming?
Okay, so let's get that clear.
Yeah.
The first level is the PHC. You should be able, because it's exchequer funded, we are assuming that Treasury puts in an amount of money at this level, and the money should be there in this pool.
Sure.
All right? Where they get the money from is budgeted. Like now, we're going into budget. It's budgeted health. Your budget comes and we say, for SHA, at the PHC level, we need 1 billion shillings. So the thought is that 1 billion shillings should be there. So that when I go and I have a fever, whatever you do the thing, it should come out of that money. But we are saying that Treasury, more often than not, does not put that money there.
Sure.
All right, clear.
Yeah.
Next.
The second one is SHIF, where we contribute 2.75 of our salary. And that money goes into the SHIF kitty, so that when you go to the hospital, then that money works for you. There is a benefit package that is cut out for that. Now, this is now where we are saying you can go to the hospital and choose that my cover maybe allows me in a general ward. And you want to go to a private.
Yes.
So you will be asked to cover for the extra. Yeah, that's where the copay bid is coming. And that's why we are saying you have to give consent. Yeah, so when you sign consent, wherever room you want me to take you, I will take you.
So the copay is on your personal preferences here?
Yes, or something that you want covered that is not within your benefit package.
Okay.
Yes.
Okay. Then, it's quite symbolic. But all the more, it's what we have. My question then is to the provider, the facilities.
Yes.
Delayed payment, delayed pre-authorization, sometimes disputed claims whereby you have a genuine claim, but then the authority finds it in itself to say that we are not going to reimburse you or pay you for this. And of course, sometimes law intake of the service from a facility, because if you've had issues with attending to patients because of share compliance, some patients will opt to go to another facility and not come to this facility.
True.
So, among many other factors, how are these factors affecting the quality of the provision of care from the facilities?
Yeah, quality of care is key. And in all these discussions, we should be putting quality of care ahead. And I'm glad there is a bill about quality of care that is still roaming around in Parliament. We need this bill out, because when you talk about quality, then you should follow with the discussion, how do you reimburse for that quality? You can't just talk about quality in isolation. But to answer your question, the quality of care in many facilities has gone down. Because look at a simple thing like the consumables that we have. Examination gloves, for example. Initially, or when cash flow is good, you find that you will want to use when you need.
Yeah.
But when cash flow is low, you would want to save it. You would want to use it only when it is necessary. And when you do that in one item, another item, the third, the fourth, it means that the quality of care itself begins to go down. Yeah, you can imagine if you go to a facility and the same needle or syringe that is pulling
someone's blood,
not even blood, but the drug from a vial, is the same one that I will inject you with.
Oh, stop it. No.
It is not a good thing.
No.
Because once that...
Are you asking us to imagine, or are you telling us what is actually going on?
I'm actually telling you to imagine, and when you imagine, it means it is something that is going. Because if you were to keep on changing that needle every time, that is cost. And this person has come to the hospital, and you have not even been reimbursed the previous visit that they come. Let me give you a good example that is roaming around, and it's happening in many facilities. We have mothers who are coming for the ANC visit.
Yes, antenatal.
Yes. And their previous delivery is not yet paid. So they are now coming for the second round when you are still waiting for the first. So what service will you give this woman? You may want to do your best, but you are incapacitated. Yeah, things like orthopedic cases. These implants that we put on people, they actually bought on cash. No supplier will wait for SHA to pay so that you can pay them. So as a facility, you have to provide. So either you provide or you ask the client to co-pay. Buy for yourself, and then we do the service. Yeah.
And this is information you've shared with the ministry. This is information that, as an association, you've compacted, compiled, and dispersed for.
And it's also public. I think also it's
yeah. So